Now I'm going to talk about ovarian masses during pregnancy. Ovarian masses. Now we can consider this topic a key topic because we have been scanning our pregnant women since the beginning of pregnancy, and therefore the detection of several lesions at the beginning of pregnancy could raise some suspicion. What about the prevalence? Is it an important prevalence, important disease, malignancy, I mean? I selected two prospective studies to tell us what is the prevalence of ovarian masses, what is the risk of torsion, what is the risk of malignancy in a general population. So these two studies were conducted in London, the first one by Kondus and the second one by Yazep. They collected, let's look at the first one, 3,000 pregnant women. They considered complex cyst or cyst with at least a diameter of 2.5 centimeters, and the prevalence was 6%. Then they followed up these patients and they observed an 86% resolution. What about the risk of torsion, of surgery during pregnancy? 4% underwent surgery because of pain, and torsion was confirmed only in 1. Regarding surgery, looking at the histology, only 1 borderline case and the other were benign. Let's look at the other experience, other 300 pregnant women. Again, the prevalence of some kind of cyst worth to follow up during pregnancy, 8%, and similar percentage of resolution. 2 cases underwent surgery because of pain, but no torsion, and 33 underwent surgery, and the diagnosis was benign in all cases. So we could say, okay, out of 6,000 patients, only 1 borderline case. So why are we talking about this issue, malignancy and so on? It's so rare. It is rare, but it's something relevant to be considered. So 1 out of 25,000 pregnancy, and looking at the paper by Hoover, if we look at the ovarian masses surgically removed during pregnancy, here you can see the different benign histology, and 3% of them were carcinomas, 3% borderline ovarian tumors. Now, I wanted to scan to look at some cases with you. On one side, some ovarian masses, they show the same features during pregnancy as well as before out of pregnancy. For instance, dermoids. We didn't notice any particular changes during pregnancy. Similarly, some other very suspicious ovarian lesions, for instance, bilateral solid tumors, like in this lady, bilateral, very well vascularized. In this patient, I always mention the history, the story, because I was scanning with the Luca Savelli in Rome, and as soon as we detected these 2 lesions, we shared, oh no, this can be a metastatic tumor. So we interrogated the woman, and regarding some stomach pain or about the last mammography and so on. And she told us, actually, I observed a very enlargement of the breast, but my gynecologist told me that it's normal during pregnancy, and it's normal. But when we looked at the situation, we said, this is not normal. So the final diagnosis was a lymphoma. So she underwent chemotherapy, and after 2-3 weeks of treatment, the pregnancy spontaneously interrupted. So after chemotherapy, as you can see, the 2 big ovarian lesions became in this way, so quite normal ovaries after chemotherapy. And luckily, also the situation of the breast. So lymphoma. Lymphoma, similar features outside pregnancy as during pregnancy. Another terrible case was this one, a huge solid mass which turned out to be a Krukenberg, and yes, the prognosis of the patient was very, very poor. Another tragedy was this one, bilateral solid ovarian mass. They turned out to be metastases from small lung cell carcinomas. In this year, we wanted at a certain moment to collect all the malignant cases we scanned, we examined, we treated during pregnancy, and this is our experience. So, the vast majority borderline, 2 mucinous borderline, 7 invasive, and 5 metastatic tumor. This is an experience in one referral center for gynecological cancer. And in this experience, we simply observed that ultrasound features were very similar to those described in non-pregnant patients, the features of this category. But there is a particular category worth to describe into details, ovarian masses with papillary projections. Several years ago, I scanned this lady, and I suggested surgery because I noticed this enlarged, vascularized papillary projection. And the lady underwent surgery, and the final histology was decidualized endometriomas. At that time, I have to admit that I wasn't aware about the possibility of this entity. But since that time, we went on and we collected several other cases, and we noticed that there is a common appearance of these lesions. So, from that point, we went on with our experience case reports and to multi-center studies on this issue. In particular, we started with this multi-center effort to collect those cases who underwent surgery during pregnancy, and the final diagnosis at histology was decidualized endometriomas. You can look at the panel and you can see that these images share a similar morphology. Again, unilocular solid with the papillary projections, but in particular, the shape of the papillary projection is smooth, rounded, and very well vascularized. So we started discussing, how can we manage these patients? Are we absolutely sure that they are benign? Because in most cases, the colleagues around the world, they suggested surgery because of uncertainty about the histological findings. So at that moment, we said, okay, we can be quite sure that if we already scan the patients before pregnancy or at the beginning of pregnancy, and we know that she had a typically endometrioma, whenever we can see papillary projection growing during pregnancy, we can reassure the lady and we can tell her it is decidualization. In the past years, we went through some very strange cases, but we were so sure about our diagnosis. And for instance, in front of this lady, it's not so easy to say, don't care, it's benign, please go on, look at the vascularization. But I did. And as you can see, during the third trimester, there was a complete resolution. In order to answer, how can we differentiate a papillary projection in pregnancy? How can we differentiate decidualization, borderline, and invasive? We ran this second study, and we collected only ovarian masses with papillary projections, surgically removed during pregnancy, and this is the distribution. We found 3 invasive ovarian tumors. I want to just to open another parenthesis talking about endometriosis because so far it has not been published something about deep endometriosis. But what happened to me? While scanning this lady, I observed that in the pouch of Douglas there was this echoic tissue. And it was not very easy to be sure about the nature of this tissue because hypoechoic tissue on the peritoneal surface can be quite suspicious for carcinomatosis. But because I was quite confident about the decidualization of the ovarian lesion, I said, oh, it could be decidualization of the nodule there. And what convinced me to go on not to operate this patient is the elasticity. Do you see, when I push my probe, it's not so firm, so hard as I experience when there is carcinomatosis. When you push against a nodule of carcinomatosis, you are not able to modify it in this way. So I suggested not to operate this lady, and after delivery, the ovary was this one. And what about the nodule of carcinomatosis? The peritoneum of the pouch of Douglas was absolutely free. No nodule. Okay, this is my story. I want to conclude with 3 new recent cases. Let's start with this one. Before pregnancy, this lady had this scan, this image at transvaginal scan. So unilocular cyst with the ground glass appearance, and that's it. At 12 weeks gestation, we observed this type of solid component inside and so on. She went on, and at 24 weeks, we observed a sort of increase, but we decided to wait. This was at 37. As you can observe here, there is a sort of shrinkage. It's not so tense, so dilated, a sort of shrinkage. And at postpartum examination, completely disappearance of the papillary projections. And so it turned out to be endometrioma because later on she was operated on. So in this lady, we can focus on these 3 steps. Actually, I would also add the examination of the 37th week because it is determinant to me. So nothing in the second trimester, the largest presence of solid component, a sort of shrinkage during the third trimester, and very often the disappearance of papillary projection after birth. Second case, very beginning at 8 weeks gestation, this multilocular solid with a solid component of 9 millimeters. At 24 weeks, we didn't observe a real enlargement in terms of dimensions and vascularization. And in postpartum examination, the lesion was absolutely similar. She underwent surgery, and this one turned out to be a mucinous endocervical type. Then we will comment later. Case number 3. 39, so a little bit older. 5 weeks at the very beginning. The detection of a unilocular solid cyst with several papillary projections. Vascularization, yes, not so rich vascularization during surgery. And within the team, she was counseled to undergo surgery, and it turned out to be a serious borderline ovarian tumor. I didn't mention the best frame time to perform surgery, that is 16, 17 weeks gestation, because you have to avoid the first trimester, and it's better to do that before 19, 20, because after that, it's very, very difficult to manage laparoscopically. Fourth case, so 41, nulliparous woman. She had a strong desire of fertility, very strong desire of fertility. So we scanned this lady at 14 weeks. So we detected a unilocular solid cyst with a papillary projection. So we were quite confident at that time. So we invited the lady to come back again in a few weeks. At this time, I was really very concerned. I can't tell you why. Was it because of these anechoic areas next to this papillary projection? I can't tell you. I should be so strong in my decision because I collected so many decidualized cases, but I wasn't so confident. But in any case, I counseled the patient. I told her it can be decidualized endometrioma, but I cannot assure. And she told me, listen, I decided this pregnancy so much, I don't want to do nothing at all. Okay, but please come in 1 month. So I scanned the lady again, and you see the transformation little by little. Again, counseling with the lady, she decided not to do nothing. So at 7 weeks gestation, instead of a shrinkage of the lesion, we observed a further enlargement and an increase of the solid component, number of papillary projections, and so on. We discussed whether to do cesarean section before or not. She strongly wanted to spontaneous deliver. During postpartum, again, instead of a shrinkage, a further enlargement, she underwent surgery, and it turned out to be a clear cell ovarian cancer, stage 1. So I presented these cases during the past ISUOG Congress in Singapore, and during the discussion, Beryl did this observation that I found it quite useful, because she said, don't you think, Antonia, that we could say that whenever we observe papillary projections at the very, very early stage of pregnancy could be a sign of something different from decidualization? And I said, oh, you're right. Indeed, do you remember this case who underwent surgery? Okay, several papillary projections, no changes at the very beginning of pregnancy. It turned out to be a borderline. So I did my effort to prepare a sort of scheme. Where am I at the moment? What do I know after all these years dealing with ovarian cysts? At the moment, I would say that if I scan a lady here and I find a unilocular solid cyst, which are my considerations? Okay. I look at the number, size, and the shape and vascularization. For sure, if I know that the lady had a previous endometrioma, I would counsel the patient in favor of a probable decidualized endometrioma, and my idea, I would expect a shrinkage in the 3rd trimester. different, and very often the disappearance of papillary projection after birth. If we don't have any scan, it's an incidental finding during pregnancy, it's very, very difficult to make any comments. If we detect several small papillary projections at the very beginning of pregnancy, and we do not observe any modification during pregnancy, perhaps they correspond to borderline ovarian tumors. It's just my observation. I don't have in my hands so many data to provide you. And the last one, if we have papillary projection at the very beginning, we observe the enlargement. Here we cannot be sure, but this is the critical moment to plan surgery. But for sure, if you don't see any shrinkage but an enlargement, you have to make a suspicion of invasive tumor. So, my conclusion. Ovarian masses detected during pregnancy. According to the two studies on general population, we can say that we can expect a resolution in several cases. The risk of torsion is very rare, according to those cases. I collected some cases, several cases, solid tumor, bilateral tumor, with similar characteristics as outside, and they turned out to be malignant. And we discussed about unilocular solid cyst, so high prevalence of decidualization. I mentioned the shape, rounded, smooth, richly vascularized. Usually, in case of decidualization, you can see the increase in size during the second trimester, shrinkage during the third trimester, and very often the disappearance after pregnancy. And I really thank you for your attention.